Hello, this is Sharon Evans. I'll be presenting a care plan presentation on congestive heart failure ages 18 to 65. Congestive heart failure is a common chronic condition that affects both genders, all races, and people in various age groups. It is estimated to be present in greater than 5 million Americans and account for more than $20 billion in medical care annually. African American males are at a significantly higher risk for incidence of CHF compared with other ethnic groups. Heart failure in African American males occurs at an earlier age and has a more severe course than in whites. Results indicate that higher rates of hypertension, diabetes mellitus, and obesity associated with poverty, suboptimal health care, and other environmental factors such as high caloric intake largely explain racial ethnic differences in the risk of developing CHF. As you can see from my concept map, I will be reviewing non-modifiable and modifiable risk factors related to CHF. Later, we'll also review left-sided and right-sided heart failure and the symptoms related to each. Next, we'll be reviewing the normal pathophysiological changes in reference to congestive heart failure. Congestive heart failure is a condition in which the heart is unable to pump an adequate amount of blood to meet the body's metabolic needs. This pump inadequacy leads to decreased cardiac output, increased preload, and increased afterload. These three events in turn result in decreased contractility and stroke volume. Some general causes of heart failure include congenital heart defects, myocardial infarction, heart valve disease, dysrhythmias, thyroid disease, and severe anemia. Heart failure can be categorized in several ways: systolic dysfunction, diastolic dysfunction, and mixed. Systolic dysfunction is characterized by decreased cardiac output due to decreased contractility. The causes of this decreased contractility include chronic ischemia from coronary artery disease, dysrhythmias, dilated cardiomyopathy, chronic alcohol abuse, and myocarditis. Diastolic dysfunction is characterized by decreased ventricular filling from abnormal myocardial relaxation and increased left ventricular pressure. This type of heart failure is caused by conditions that stiffen the myocardium, such as coronary artery disease, hypertrophic and restrictive cardiomyopathy, and pericardial disease. Most patients have a combination of systolic and diastolic dysfunction known as mixed dysfunction. Heart failure can also be classified as either left or right-sided. Left-sided heart failure is a result of ineffective left ventricular contractility. As cardiac output falls, blood that is not being pumped out into the body backs up first into the left atrium and then into the pulmonary circulation. Pulmonary congestion, dyspnea, and activity intolerance develop as blood backs up into the lungs. If blood continues to accumulate, pulmonary edema and right-sided heart failure will develop. Common causes of left-sided heart failure include left ventricular infarction, hypertension, and aortic and mitral valve stenosis. Right-sided heart failure is a result of ineffective right ventricular contractility. As a consequence of this condition, blood does not move appropriately out of the right ventricle. Blood backs up first into the right atrium and then into the peripheral circulation, causing increased pressures in the peripheral capillary bed. The patient begins to gain weight as fluid is not excreted by the kidneys. Tissues become edematous as pressure in the capillaries push fluid out of the circulatory system. The most frequent cause of right-sided failure is increased pulmonary resistance because of respiratory disease. Additionally, pulmonic and tricuspid valve stenosis can strain the right side of the heart. Most patients have a combination of left and right-sided heart failure. Next, I'll be reviewing body systems. in reference to congestive heart failure. The first system I will review is the cardiovascular system. As I said before, congestive heart failure is a condition that damages the heart muscle. This damage makes the heart muscle stiff or thick and the muscle weaker. When the heart muscle is weakened, it is less forceful in pumping throughout the body and less blood moves out of the heart. The body has several ways to try to keep the same amount of blood flow moving. First, the heart chambers stretch to hold more blood. This does help keep blood moving, but only for a while. Just like a balloon that is stretched again and again, the heart eventually loses its ability to return to its normal shape. Over time, the heart walls become thickened and the chambers remain enlarged. They become unable to return to their normal size. With thickened heart muscle walls, not enough blood can enter the chamber. Congestive heart failure also affects the valves of the heart. Valves open and close to control the blood flow within the heart. Stenosis or narrowing of these valves causes a backup of blood in the valve. If the valve cannot close right, a backflow of blood or regurgitation could occur. In addition, the mitral valve between the left atrium and the ventricle often becomes broken during the heart failure, causing blood to leak back into the left atrium, resulting in mitral regurgitation. The next system I'll be reviewing in reference to congestive heart failure is the respiratory system. Congestive heart failure affects not only the cardiovascular system, but every organ system involved with oxygen transport, including the respiratory system. There are several clinical manifestations of the respiratory system related to heart failure, such as shortness of breath, pulmonary congestion, orthopnea, paroxysmal nocturnal dyspnea, and hemoptysis with blood-tinged sputum. As we all know, pulmonary edema is often caused by heart failure. When heart failure is not able to pump blood to the body efficiently, the amount of blood staying in the veins that take blood through the lungs to the left side of the heart increases. As the pressure in these blood vessels increases, fluid is pushed into the spaces in the lungs. This fluid reduces the normal oxygen amount through the lungs, which can lead to shortness of breath. Hemoptysis with blood-tinged sputum occurs as the buildup of the lungs becomes very severe. A frothy pink fluid can be coughed up. Orthopnea occurs when congestive heart failure worsens. Fluid backs up into the lungs and interferes with oxygen getting into the blood, causing dyspnea at rest and at night. The patient may also awaken at night, short of breath, and have to sit or stand up to get relief. This condition is known as paroxysmal nocturnal dyspnea. Next, I'll be reviewing how congestive heart failure affects blood flow. Congestive heart failure directly affects blood flow to and from the heart. At the onset, CHF damages the heart muscle. The damaged muscle either cannot relax properly to let pumping chambers of the heart fill with enough blood, or it cannot contract properly to let the ventricles pump out enough blood. The left ventricle is the main pumping chamber, and heart failure usually starts on the left side. As your heart pumping action lessens, blood may back up into your lungs, liver, or legs. We'll move on to the urinary system. Congestive heart failure reduces the amount of blood flowing to the body. The kidneys compensate by constricting the blood vessels to allow salts and waters to remain in the blood, which in turn causes them to filter less fluid out of the circulation into the urine. The increased blood volume only adds to the strain on the heart, therefore causing the heart failure to worsen. The resulting reduced blood volume interferes with kidney function, leading to kidney failure. Kidney failure means the kidneys cannot remove excess fluids and salts from the blood. The resulting increased volume of blood increases the blood pressure and causes the heart to work harder. Therefore, over time, kidney failure can cause congestive heart failure itself. Next, we're going to move on to the endocrine system. Several changes occur when the endocrine system is affected by congestive heart failure. The changes include general neurohormonal activation with stimulation of the sympathetic nervous system, the renin-angiotensin-aldosterone axis, and the natriuretic peptide system. Initially, these systems are thought to be compensatory effects, but eventually they contribute to increased vascular resistance and ventricular remodeling. The normal hormonal hypothesis postulates that heart failure progresses because the activated endogenous neurohormonal systems exert a deleterious effect on the heart and circulation. Several studies have found that neurohormonal activation to be strongly related to mortality. Now we're moving on to the musculoskeletal system. In CHF, the reduced cardiac output causes a number of changes in the rest of the body. One such change is in the skeletal muscle. Reduced perfusion of the skeletal muscle causes atrophy of the muscle fibers. This can result in weakness, increased fatigability, and decreased peak strength. All these contribute to exercise intolerance. Next, we'll be reviewing fluid, electrolyte, and acid-base homeostasis. One of the most significant signs of congestive heart failure is fluid retention that can build up in the arms, legs, and ankles and feet. Right-sided heart failure is a result of ineffective ventricular contractility. As a consequence of this condition, blood does not move appropriately out of the right ventricle. Blood backs up first into the right atrium and then to the peripheral circulation, causing increased pressures in the peripheral capillary bed. Weight is gained as fluid is not excreted by the kidneys. Tissues become edematous as pressure in the capillaries push fluid out of the circulatory system. This phenomenon is called edema. Edema is a problem with fluid distribution, not necessarily a fluid overload. It results when hydrostatic and osmotic forces favor fluid moving from the intravascular compartment to the interstitial place. Edema occurs when hydrostatic forces are greater than the osmotic forces. We see this when blood stagnates in the periphery with heart failure, thereby increasing hydrostatic pressure and pushing fluid out of the vessel, and of course, causing fluid buildup in the arms, legs, ankles, and feet. Electrolyte and acid-base abnormalities are a frequent and potentially dangerous complication in subjects with congestive heart failure. The common electrolyte abnormalities are hyponatremia, hypokalemia, and hypomagnesemia. The acid-base disturbances generally observed are metabolic alkalosis, pure or combined, with respiratory alkalosis. The decrease in cardiac output leads to a reduction in the renal blood flow, with the impairment of the renal excretion of water and electrolyte, and it causes activation of several neurohormonal responses, which affect both homeostasis and electrolyte balance. Next, we'll move on to the gastrointestinal system. If blood is not flowing correctly to the heart, other circulatory areas are affected, including the gastrointestinal system. Gastrointestinal function is affected in several ways by congestive heart failures. Some ways include fluid retention, intestinal ischemia, constipation, and drug malabsorption. As the heart's pumping becomes less effective, blood may back up into the gastrointestinal tract, causing ascites. Intestinal ischemia occurs when blood supply of oxygen-rich blood flow to the small intestine or colon is blocked or altered, and the digestive tract cannot function properly. It becomes impossible for the intestine to absorb food and nutrients. The result is bloody stools or diarrhea. If left unattended, infection and gangrene can result. Constipation is a common complaint among patients with heart failure. It can be a manifestation of decreased intestinal transit secondary to poor perfusion. The pathophysiological circumstances of CHF modify the rate and/or extent of drug absorption as well. In CHF, gastric emptying tends to be decreased either due to the presence of coexistent diseases affecting motility, like diabetes, or as a consequence of sympathetic nervous system activation and or concomitant drug therapy. Furthermore, autonomic disturbances such as increased sympathetic and decreased parasympathetic activity and or tissue hypoperfusion characteristic of CHF will frequently reduce gastrointestinal motility and thereby slow transit time. This could delay oral absorption and, depending on the drug, either increase or decrease its absolute bioavailability. Moving on to the reproductive system. Research in reference to the correlation between congestive heart failure and the female reproductive system was limited. However, there is research that indicates increased risk of pregnancy complications with a diagnosis of congestive heart failure. Pregnancy stresses the heart and circulatory system. During pregnancy, blood volume increases by 30 to 50% to nourish the growing baby. The amount of blood the heart pumps each minute also increases by 30 to 50%. Heart rate increases as well. These changes cause the heart to work harder. Labor and delivery add to the heart's workload too. During labor, particularly when pushing, patients experience abrupt changes in blood flow and pressure. When the baby is born, decreased blood flow through the uterus also stresses the heart. As blood volume increases, congestive heart failure can get worse. In addition to the disease itself, there are several medications used to treat congestive heart failure that are contraindicated during pregnancy. Like the female reproductive system, there was limited information linking congestive heart failure to the male reproductive system. However, heart failure patients experienced a decreased libido and frequency of coitus, negative changes in sexual performance, and general dissatisfaction related to their sexual function. Other research also found that there are many drugs used to treat congestive heart failure that can cause or exacerbate erectile dysfunction in men. These medications include beta blockers as well as antihypertensive drugs such as ACE inhibitors. This may in turn lead to non-compliant and misguided efforts to retain satisfactory sexual activity, with secondary worsening of cardiac capacity. The neural system is next. Autonomic disturbances, increased sympathetic and decreased parasympathetic activity are characteristic of CHF. The sympathetic branch of the autonomic nervous system is activated during heart failure and serves as an important compensatory mechanism. This results in cardiac stimulation, peripheral vascular constriction, and activation of the renin-angiotensin system. Parasympathetic outflow to the heart is reduced in patients with heart failure, resulting in increased heart rate and decreased heart rate variability, both of which are correlated with increased mortality. The sensory system. Outflow from the central nervous system in heart failure affects several key organs, including the heart and kidney. When referring to the heart, the sensory endings of the vagal and sympathetic afferent fibers are mechanoreceptors and thereby stimulated by the mechanical stretching associated with cardiac dilation. When the heart dilates, vagal and sympathetic afferent cardiac fibers increase their firing, and this afferent sympathetic excitation leads to tonic and reflex inhibition in cardiac vagal efferent activity. This can be expected to occur whenever the heart dilates in heart failure due to systolic dysfunction. When referring to the kidneys, efferent renal signaling decreases renal blood flow and contributes to volume dysregulation, and afferent renal signaling contributes to cardiac sympathoexcitation, baroreflex dysfunction, and arrhythmogenesis. The last system I'll be reviewing today is the integumentary system. Congestive heart failure causes a number of skin manifestations, such as bluish skin around the mouth due to decreased oxygen in the blood, pale, mottled, or grayish appearance to the skin of hands and feet due to poor perfusion, dry skin on the lower part of the legs because of pressure from inside the tissue caused by edema, as well as skin conditions such as stasis dermatitis, cellulitis, and leg ulcers. Stasis dermatitis is a skin condition that develops in people with poor circulation from congestive heart failure. Blood pools in the veins of the lower leg. Fluid and blood cells leak out of the veins into the skin and other tissues. At first, the skin in the ankles and the lower legs may look like tissue or look very thin. Patients may slowly get brown stains on the skin. This may lead to itching and inflammation, and the skin may become irritated or crack if you scratch it. It may also become red or swollen, crusted, or weepy. Over time, some skin changes become permanent, such as thickening and hardening of the skin on the legs and ankles, bumpy or cobblestone appearance of the skin, dark brown color. In serious cases, stasis dermatitis can progress into cellulitis and leg ulcers. Cellulitis is caused by excess fluid buildup in the feet and legs of a person suffering from congestive heart failure, and the ability of the body to supply adequate oxygen to these cells can lead to an infection of the skin and the tissues of the legs and feet. Cellulitis can be life-threatening if left untreated. A person with cellulitis caused by congestive heart failure infections will present with redness and warmth and swelling of the tissue of the affected areas. The skin may burst and the excess fluid seep out. These open weeping areas are then more prone to developing subsequent infections. Last, venous ulcers can occur when the veins in the legs don't push blood back up to the heart as well as they should. The veins in the legs have one-way valves that keep the blood flowing up towards your heart. When these valves become weak, blood can flow backward and pool in your lungs. The excess fluid causes the blood pressure to build up in your legs. The increase in the pressure and the buildup of fluid prevent nutrients and oxygen from getting to the tissues. The lack of the nutrients causes cells to die, damaging the tissue and causing an ulcer. Venous ulcers present as shallow sores with a red base, sometimes covered by yellow tissue, unevenly shaped borders. The surrounding skin may be shiny, tight, warm, or hot. Next, we'll be moving on to the modifiable versus the non-modifiable factors of congestive heart failure. Modifiable factors include alcohol, smoking, obesity, diabetes, and hypertension. And the non-modifiable factors include age, gender, family history, and race. The next portion of my presentation are the care plans associated with congestive heart failure, whether they're with the modifiable factors or the non-modifiable factors. The non-modifiable factors are factors that can't be changed, such as age, gender, family history, or race. I did a care plan, and the goal for this care plan was to reduce or remove the risk of developing congestive heart failure despite the risk factors related to congestive heart failure. The intervention that I believe are necessary is to make the patient aware of non-modifiable risk related to CHF, educate on the importance of following a healthy lifestyle, educate on taking medication as prescribed by your physician, educate on the importance of limiting the amount of saturated fats and trans fats that you eat, educate on the importance of not smoking, educate on leading an active lifestyle, and education on the importance of not abusing alcohol. My next set of care plans are on the modifiable factors related to congestive heart failure. The first modifiable factor I'll be discussing is diabetes. The goal for diabetes is that the patient will verbalize adherence to diabetes and the management plan that was provided by the physician. Nursing interventions would be the primary intervention would be to assess adherence with the treatment plan, such as diet, checking blood sugars, medications, and follow-up visits. Secondary would be provide diabetes education on health complications, hypo and hyperglycemia, feed inspection, podiatrist visits, eye exams, hemoglobin A1C, and diet. Tertiary would be stress the importance of checking blood sugars as recommended and record the results to share with your provider. Some thoughts on uses of technology would be to download blood sugars directly from your smartphone to your provider, or maybe a medication adherence app on your smartphone. The next modifiable factor would be obesity. The goal for this would be adherence with healthy eating habits. The primary intervention would be to educate on low sodium diet, types of fats, reading labels for fat and sodium content. The secondary intervention would be educate on the importance of physical activity of at least 30 minutes per day. And the tertiary intervention would be refer to a registered dietitian for nutritional counseling. Technology related to this modifiable factor would be food tracker app, electronic scale that records weight and downloads the results to the physician. My next care plan is on hypertension. The goal for hypertension is that the patient will verbalize adherence with the hypertension management plan. The primary intervention is to educate on normal blood pressure range, educate on hypertension and its effects on the heart, blood vessels, kidney, and brain. Secondary intervention would be to educate on the importance of taking medications as prescribed, adhering to the treatment plan and keeping follow-up appointments, and taking your blood pressure at home daily. Tertiary intervention would be to educate on diet that low in sodium, fats, and cholesterol. Use of technology for this care plan would be a blood pressure cuff that downloads results directly to the physician, a food tracker app that identifies sodium, fat, and cholesterol content of food, and just like with diabetes, a medication adherence app to make sure that the patient is taking the medication as prescribed. My next care plan is on smoking cessation. The goal for smoking cessation, of course, is that the patient will refrain from smoking or at least decrease their smoking. The primary intervention is to educate on hazards of smoking. Secondary, provide information on smoking cessation support groups. Tertiary, refer to a physician for smoking cessation, medication, or aids to assist with smoking cessation. Use of technology could be telephonic follow-up or mobile smoking cessation support groups. My last care plan is on alcohol abuse. Of course, when it comes to alcohol abuse, you want the patient to refrain from drinking or abusing alcohol. The primary intervention for this is to educate on the dangers of alcohol abuse. Secondary, encourage the patient to gain support from family or friends to help with to refrain from drinking. Tertiary, provide resources for treatment programs. Use of technology for this care plan would be mobile support group that can be accessed via a cell phone or internet, so that the person has additional support to refrain from drinking. In conclusion, considering the worsening epidemiologic trends and increase in the heart failure prevalence in the society, escalating costs, and continued poor quality of life and outcome for these patients, the importance of heart failure prevention cannot be overemphasized. Attention to improvement of the overall cardiovascular risk profile, including physical activity, weight loss, alcohol consumption, smoking cessation, and control of hypertension and diabetes, should play an important role in the prevention of CHF in the U.S. general population. Prevention and adoption of a healthy lifestyle habits are essential to promote overall cardiovascular health and reduce the risk of heart failure.